Good morning, everyone. I'm Dr. Vijay, consultant rheumatologist at Divisha Arthritis and Medical Center and Manipal Hospitals, Bangalore. First of all, apologize for the 10-minute delay. This is because of a technical snag due to internet problem in the web hosting platform and also from my end. So we have started this Divisha patient education series where uh, 2 Sundays before um, I spoke about arthritis in general and rheumatoid arthritis. Today I'm speaking about a very important topic called ankylosing spondylitis, or also called as inflammatory spondyloarthritis. So, this topic is very important because there are lots of myths about this, and there are quite a few misconceptions about this, and important thing being it's mainly affects people of young ages. So it is very important that one clearly understands what exactly is the present problem, or how we deal about this situation. uh, just a minute break. Right. So I'm Dr. Vijay Rao. So I've had my general medicine and rheumatology training from the United Kingdom. So this is the place where these were the centers where most of these diseases were extensively studied. Research trials are still done, and many centers are part of this European initiative called Assessment of Ankylosing Spondylitis International Group, or ASAS. So quite a few of my professors were of this international group, and were all by treatment guidelines, clinical diagnostic guidelines, approach to treatment, so on and so forth, have been devised. So I've been back in India now for the last 6 years and been a full-time consultant in Manipal Hospital, Bangalore. And I'm currently speaking from Divisha Arthritis and Medical Center, which is a dedicated rheumatology unit where we cater with only rheumatology autoimmune diseases such as rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, vasculitis, systemic lupus erythematosus or SLE, fibromyalgia. So we have physiotherapy, musculoskeletal physiotherapy, who caters to our patients. We have a dedicated autoimmune lab partnership with Anand Labs, who are the country's best and NABL accredited. And we provide subsidized medications to patients from our own pharmacy, so that because these are long term diseases and patients have to take medicines over a long time. We also have a therapeutic yoga unit, which is very important to the present topic I'm talking about. Okay, so with that background, let me just speak about what I'm talking today. Understanding ankylosing spondylitis. What exactly is that? So this is a patient education program. I thank Pfizer for actually providing this platform, and this is greatly helpful to talk to my patients. I'm so pleased to talk to you all, and thank you very much for spending your Sunday with me and waiting for 5-10 minutes we become live. I appreciate your gesture. This is purely to help you people out so that all your anxieties are allayed and you get a proper care, and you are happy in life. That is the main motto of this. So just a brief few slides about what exactly is arthritis. Arthro means joint, itis means heat or inflammation. So it is inflammation in the joints. And broadly, you can divide arthritis into age-related, which is osteoarthritis, where most people get confused that arthritis affects only old age. So this is the arthritis, that is osteoarthritis, which affects old age. And rheumatoid arthritis or seronegative arthritis, which is inflammatory arthritis. Okay. So, rheumatoid arthritis, we generally spoke about last week. So, this is basically inflammation affecting small joints of the hands and feet, which is more common in females. And it's an immune system which is attacking our own joints, such as hands and feet. Okay. So, rheumatoid arthritis mainly affects both sides of the body equally. Uh, and usually it's a long-term disease and, driven by the antibodies. And seronegative arthritis is one of them I'll be talking today. Basically, sero means blood, negative means your rheumatoid factor and anti-CCP antibodies will be normal. So seronegative means blood normal arthritis, but still here inflammation or autoimmune system, that is in immune system in the body, develops antibodies which are not detectable in blood and attacks own joints. So important here is it attacks one joint at a time or one side of the body, not both sides of the body. And it attacks big joints such as lower limb joints, hips, knees, then feet, and most importantly spine, that is neck, hips, so on and so forth. Okay. So the main difference is this: seronegative arthritis usually affects men. Okay, men are more commonly affected in the age group of 15 to 45 years. Okay, so I'm talking one of the topics on seronegative arthritis today. But before that, I spoke about this 2 weeks ago as well. All these statements are all false, my friends. Arthritis affects in old age only. Wrong. No treatment is there. Wrong. There is no cure. Wrong. Affects only joints. Wrong. It affects many other parts of the body, which I'll talk about in detail. Tablets have many side effects. Wrong. Disability with all arthritis. Oh my God, I'm going to get disabled. All my life is gone. All these are false. They are false, my friends. They are not true. What is true, I'll tell you. It affects all ages, including children. Some of my patients are as young as 6 to 7 year old kids. If you reach me or any other rheumatologist within 3 months of your symptoms, it can be cured. That is, tablets could be stopped and treatment disease might not come back provided you follow your diet and lifestyle changes, which I'll talk about in detail. And what is true is there's no disability with good treatment. My friends, you can lead normal life. Absolutely normal life you can lead. You can achieve your dreams. You can do whatever you want. So telling that, oh, my life is spoiled is wrong. It's wrong. Okay. Arthritis affects other organs also. That is the truth. That is why you need to see a rheumatologist. It affects head to toe, every single organ of the body it affects. So it's not just joints we are dealing with. We deal with connective tissue diseases, connecting different organs of the body. So this truth is only known to a rheumatologist, my friends. So that is the importance or difference between seeing an orthopedic and a rheumatologist. Because an orthopedic treats only joints, we treat the whole body. We treat the whole patient. We don't treat the diseases. Our motto is to make you feel better in total so that you lead a normal life, my friends. It can be fully controlled with tablets. Even if you present a rheumatologist late, don't be disheartened. It can be fully controlled, whatever autoimmune diseases, including the today's disease I'm talking about. It just may take a bit time if you reach a bit late to your rheumatologist, but you will get there. And tablets can some patients we slowly reduce the treatment and stop. There's no major side effect at all with tablets, my friends. Most of the tablets are quite good. Only after you try, we will know what suits you and what doesn't suit you. And after that, a rheumatologist who you're treating with will be able to take a decision of what best tablet suits you with minimal side effects. Okay. So this is the truth. You must know this, my friends. So who is a rheumatologist? Who are we? So we are people with medical background. We are internists or pediatricians. Most of us are adult treating patients, that is general medicine or general pediatrics. Then we have received 4 to 5 years training. Like I trained in the UK, so we received 4 years of immunology training and rheumatology training. We only study autoimmune diseases, and we are physicians. We are not surgeons. Okay, and we deal with diseases which affects whole parts of the body. Okay. And we deal with the treatment, we deal with the complications, we deal with the side effects. And our aim is to make your joints, muscles, bones pain free and without deformity, and we don't do surgery. The only benefit of being a rheumatologist early is we prevent patients from going to surgical stage. So that is the key importance of seeing a rheumatologist early. No point in seeing a rheumatologist after you have had a complete knee erosion or damage or osteoarthritis or complete hip or erosion or damage or osteoarthritis. So that is not the stage we want patients to come to us, my friends. Tell your people who have been having arthritis at young age, 15 to 45 years, to please see a rheumatologist. Please see a rheumatologist early so that complications are minimized and we prevent patients from going to surgical stage. This is the main difference of seeing a rheumatologist, my friends. Okay. Now, if you have or anybody you know have pain, swelling and stiffness in the joints, any joint, back pain, which is worse in the second half of the night or early half of the morning, more in cold weather and wet weather, along with any associated symptoms like fever, skin rashes, so on and so forth, you must tell them to contact rheumatologist. This is the take home which you will take home today, okay, and spread to your family and friends also. So types of arthritis we've already dealt with. Broadly, old age arthritis, that is osteoarthritis. Then uric acid causing crystal arthritis or gout. Most commonly, even orthopedic doctors and non-rheumatologists and patients are confused over, sir, I have pain, my uric acid is high, I'm told I have gout. Please, that is wrong. Please, 95% of Indian population will have high uric acid above 7. That doesn't mean it's gout. Gout is basically a typical red, hot, swollen, big, inflamed, big toe, like tomato, cherry tomato, it becomes. That is gout due to uric acid. Gout doesn't affect many joints at a time. It doesn't linger all the time. It comes and goes, comes and goes. So that is gout. So we don't check uric acid unnecessarily. Uric acid is managed with diet and exercise, please. Treatment we don't give for everybody having high uric acid because it has complications. So only with gout and uric acid we call it as a gout problem and give uric acid medications. Other common ones which we deal with, rheumatoid, which I dealt with 2 weeks ago, and psoriatic arthritis, which I'm talking about in next 2 to 3 weeks. Ankylosing spondylitis, which I'll talk in detail. Seronegative arthritis is a broad term which encompasses psoriatic arthritis, ankylosing spondylitis, and several other things which I'll talk about now, and SLE and connective tissue diseases. Right. So, what is inflammatory spondyloarthropathy? You have the following diseases under this umbrella which I'm talking today. Ankylosing spondylitis is in the core part of which affects the spine, that is the true classical ankylosing spondylitis. Or you may have a psoriatic arthritis with spine involvement. You have a patient with acute anterior uveitis where eyes become red, swollen, inflamed, watery, where you have to rush to an ophthalmologist to take drops. So that is what is uveitis. Some of these patients, about 40% of these patients, are ankylosing spondylitis, where the disease, the symptoms which I'm talking today, they'll be having that. Then, of course, any GI infection, that is stomach infection or urine infection, can lead to pain, stiffness, and swelling in the joints, especially in the spine, causing ankylosing spondylitis, that is called reactive arthritis. Then you have inflammatory bowel disease causing ulcerative colitis, Crohn's disease, with also spine inflammation. We call it enteropathic arthritis or inflammatory bowel disease. Then you have juvenile spondyloarthropathy or your kids having ankylosing spondylitis features. All right. So, conquering ankylosing spondylitis. What is ankylosing spondylitis? It's a type of arthritis which affects young people between 15 to 45 years, causes inflammation in all these red areas from neck, mid-spine, lower spine, and hip joints. Not only joints, it affects ligaments of the spine and hips. Over the time, inflammation in the joints and tissues can lead to back pain, stiffness, leading to a rigid spine. In severe cases, the spine may fuse and join each other, where it's also called bamboo spine. So that's what we rheumatologists don't want. So if you look at which population it affects, it's usually 15 to 35 year age group, 15 to 35 year age group men, more common in men, five times more common in men. And its prevalence may vary between 0.1 to 2% in different populations. It's not a very common disease. However, it's not very rare either. Most often you missed because back pain is very common. About 80% of us like headache have back pain in life. So unless we know what is the back pain for which I need to see a rheumatologist, gets missed. Okay, that's the idea of today's talk. So there's no specific cause, but it has genetic and environmental factors involved in that. And the gene which is affected is HLA-B27 gene. About 80 to 90% of cases in a classical ankylosing spondylitis. However, not everybody who has the gene who develop. 1 out of 30 people develop the condition. It is what it is said. Okay, and we necessarily doesn't say it is truly a heritable disease, but this we often see population in the same first degree relatives. A lot of people having HLA-B27 gene, and hence when the gene gets mutated, they have the disease. Okay. So signs and symptoms usually begin in late adolescence or early adulthood, that is 15 to 25 years or so. So you have neck pain and stiffness, you have arthritis in shoulders and hips and lower back. So typically patients say pain in the buttocks or back of the thighs, and which is worse in mornings and wears off with activity or exercises or during the day. That's the typical symptoms patients present. Other symptoms are, enthesitis causing what we call as tennis elbow kind of symptoms. So that is this part of the elbow having pain, if you see here, okay. And you have rib pains, that's sternum pain and sides of the ribs pain, causing that what we call as sternitis or costochondritis. Then you have Achilles tendon pain, that is ankle, back of the ankle pain, heel pain. So that is plantar fasciitis around the heel, especially morning time. Back of the ankle and heel, especially when you step foot on the floor, causing pain. And you have swollen fingers. In dactylitis is what we see, where some of the fingers get swollen, knuckle joints get swollen. And in about 30 to 40% of patients, when you ask them, they typically say that once a few times their eye had become red or swollen, either one eye or both eye, and they had to rush to ophthalmologist to get drops. Okay, so that is what patients can tell. So you see that it does affect organs other than joints. So that's a key take-home message for you, my friends. Then, so how does a doctor or a rheumatologist diagnose ankylosing spondylitis? Obviously, the doctor takes history, all the symptoms I went through, there's relevant physical examination. Then later on, he or she requests X-rays or MRI, and then blood tests, or of course, along with that, and then makes a diagnosis. It's not just your test. Symptoms are very, very important. That's the reason for this picture. Symptoms are very, very important, my friends. So your doctor or rheumatologist might say morning stiffness lasting for more than 30 minutes, better with activity, worse with rest, or you get woken up in the night because of pain, rolling over in the night from side to side, and stiffness because of pain. And if you're having alternating buttock pain, with prolonged sitting. So these are typical symptoms which patients often report. Patients often report these symptoms. Okay. So uh, what do the doctors check or doctors check? They check your forward bending and backward bending. That's called flexion and extension. Typically, in this disease, bending forward or touching the toes with the knee straight is very difficult. Or bending side by side. This is the first movement that gets affected. You have pain and you bend sideways like this. Or even rotation, where you stand and move your chest sideways, and chest expansion, breathing, because of the tightness gets affected. Okay, so these are common examinations which your rheumatologist or your doctor does. So they typically do this test called modified Schober's test, where in normal people they mark on the 2 points in the posterior dimples. They're called dimples above your buttock. One above 10 centimeters above they mark, and they hold the tape there, and they measure how much movement you're having. It should be at least 15 centimeters. The measurement, or at least 5 centimeters movement should be there. So if you're having reduced movement, so they say that you are having an active disease, So the other movement which is usually done is chest expansion, where because it affects the chest bone and side rib bone, expanding lung is very difficult in this. So that is very, very crucial, because patients often report that in the middle of the night they're not able to breathe and they're having tightness or pain in the ribs. And most patients, my friends, go to heart doctors saying, I have heart problem, I have heart attack. And heart doctors call us and telling that if all listen tests are normal, the heart is normal, I think they have what we call as ankylosing spondylitis, please see them. So this is something which you must remember as well. Okay, it affects something called central skeleton of the body. See this knee. This is a normal knee. There is fluid in there. So this typically in ankylosing spondylitis, we call it peripheral ankylosing spondylitis. You see that only one joint, right joint in this young male is affected. There's fluid around this. Okay. Uh, and here you see Achilles tendonitis. That is what I was telling. This is a tendon which connects the calf to the heel, and it's swollen. Compared to this, you see there is swelling in this side. So this is, the patient is standing from backwards, so this is the right side of the patient, right Achilles tendonitis. Okay, so if you look at why this is caused, you see this picture shows that, so this is a muscle which attaches to the bone there, and when it attaches through a rope called tendon, and the attachment site is enthesis. So if you look at the enthesis, this part which is magnified here, in normal enthesis, this is the ligament, the muscle ligament, and the enthesis part, this is the junction of the bone and that. This is normal. Here you see it's all damaged, it's filled with cells, all the autoimmune cells, and it's damaged. It is now realized that the process of ankylosing spondylitis actually starts in the enthesis, or they say that it's IL-23 or IL-17 driven, interleukin 17 or 23 driven pathology. So one of my own colleagues, where I trained in UK, from Oxford, did this groundbreaking research on IL-12-23 pathway of enthesis, where he found that when they did rat studies, that the interleukins were seen more commonly around this area, the enthesial area, where the muscle attaches to the bone. Okay, so that is where you're actually, this muscle is attaching to this bone. That is where you're seeing. So similarly, you see this part in heel, you see this part in elbows, you see this part in sides of hips. So when some other people, or including some of the non-trained or non-rheumatology doctors, examine patients, they don't see this and they say you're normal, you're normal, you're normal. But patients keep telling, I have pain, sir, I have pain, I have pain. And sometimes patients starts crying out when they reach that, sir, people are not believing me, but I have pain. This is the reason. Enthesis cannot be seen. That's where MRI or ultrasound becomes crucial, because it doesn't show up on the MRI, on the X-ray in the early stages. You need MRI or ultrasound, or a careful clinical eye to look into that. That's very, very important. So you see here, this patient's spine, it's almost become spine straight, and there is curving here, and there's bending, slight bending in the knee joints there. So that's typically, is called as what we call as typical posture of ankylosing spondylitis. We certainly don't want that. Okay, and in case of an eye, we call uveitis or iritis. So usually it's sudden onset, comes on suddenly, and troubles patient. It's usually on one-sided, but can be, it's seen in 30 to 40% of patients with ankylosing spondylitis. In 50% of cases, it can be both sides, and in 40% of cases, it can be recurrent, or that is again and again happening. And usually, sometimes even without treatment, it goes away. But most oftenly, patients have to rush to ophthalmologist to get steroid drops, or even painkiller tablets, and often related to HLA-B27 defective gene, which I told you about. Okay, so see, there is pus collection in the, what we call as anterior chamber of the eye. This patient has red eyes, and here also you can see the inflamed, iris. The 25% of patients with ankylosing spondylitis have psoriasis. So this is a typical patient who has what we call as palmar psoriasis. with flaky skin. Okay, you see this. And same patients have nail disease as well. So the nail gets chipped off, there's ridging. So all these are signs which one has to look out for if somebody develops back pain, whether they have these kind of pathologies. In 25 to 30% of cases, you might have all this. And here also you see the one marked with black things, the psoriasis patches are seen here. And if you see the other fingers and compare this arrow, this finger is swollen. We call it dactylitis or sausage fingers. The whole fingers get swollen. So it's not only this arthritis, you have tendinitis, what we call as tenosynovitis, all the ligaments, skin, everything, soft tissue gets swollen here. Okay, and there's nail disfigurement as well here due to psoriasis. So this is psoriatic plaque lesions causing dactylitis and ankylosing spondylitis. Right. So what are the blood tests we ask for? Friends, remember this. Most doctors don't know this. Some of the rheumatologists as well. Listen to this very carefully. Blood tests are normal in 60% of patients of ankylosing spondylitis. 60%. That is 60 out of 100 patients have normal blood tests. So having normal blood test doesn't rule out a disease, please. Physical examination, symptoms and history and examination. Very, very, very important, my friends. Very, very important. This thing has to be noticed. That is where most of the diagnosis is getting delayed, because if ESR, CRP, which are markers of inflammation, are high, most doctors refer to rheumatologists and say this patient has ankylosing spondylitis, please treat. But if they are normal, patients are sent off most occasions, or patients themselves say that I have normal blood test, I don't have arthritis. That is wrong. Okay. If ESR, CRP is high, it means it's a severe disease. If it is normal, it doesn't mean you don't have a disease. If it's high, it means a severe disease. It means it needs stronger, higher treatments. Actually, B27 we often test, and the method we have to do is PCR method, not flow cytometry. The best sensitivity and specificity is for PCR method only. Okay. So even if flow cytometry comes normal, we ask for PCR method. So blood tests, these are the main blood tests we look for. Of course, we look for anemia. If ESR, CRP is high, bone marrow production is stopped, anemic will be there. And if ESR, CRP is high, patients become very fatigued and tired, and lack of interest, motivation, excessive tiredness because of low hemoglobin and all that. Okay. X-rays. So both X-rays and MRI will show whether there is any present inflammation or damage. And it's also helpful to start before treatment and after treatment. It will show us how was the disease before treatment and how was it after. Listen to this again. X-ray changes takes at least 2 to 3 years to develop or see signs of ankylosing spondylitis, my friends. At least 2 to 3 years. So my patients, the way things are, I take a detailed history, I examine. If the patients are having typical signs and symptoms of ankylosing spondylitis, that is inflammatory back pain, less than 45 years of age, later half of the night or first thing in the morning, stiffness in the back or the neck or the other joints, which gets better with activity or painkiller, or which gets worse when they rest, I definitely think that this patient has ankylosing spondylitis. And that stage I examine and confirm how is their neck, neck movement, how is their neck movement, how is their bending of the spine, how is their hip rotations, whether they're able to, what we call as, cross leg, they're able to sit down, or we examine, we see that. And at that stage, I ask for, blood tests. I don't ask for HLA-B27 generally. I ask for ESR, CRP, and I ask for X-rays. If X-ray shows signs of ankylosing spondylitis, which I will come to shortly, I don't ask for HLA-B27 because that is not required. If the X-rays and MRI are normal, then HLA-B27 becomes important. HLA-B27 is also important to say that probably treatment cannot be stopped. Some degree of low degree of tablets has to be taken because the disease might come back. Okay. So if you see here, this patient had a normal X-ray, but it was shown that the patient had ankylosing spondylitis on MRI. That's called non-radiographic axial spondyloarthropathy. So this is MRI proven disease. That's a new term now. But in 2 years, they actually, uh, they had raised CRP at the start. It was more than 6. And they said, dude, whoever had more than 6 of CRP, they had 4 times more chance of, 4 times, that is 4.1, 4.1 is the odds. So 4 times more chances of developing the disease within 2 years. And you see X-ray changes in the left-sided sacroiliac joint already seen. So raise CRP of 6, very important, very important, very, very important. Okay. So remember that. Then X-ray changes. So we see something called squaring of spine. We see syndesmophytes. If you closely come forward the screen and look, there's a small line or hook-like thing there that attaches there. That's called syndesmophyte, or also called shiny corners, seen on X-ray. It needs an eagle eye and to a being which knows what they're looking at. So that's where rheumatologist comes handy. So they look at this and they make a diagnosis. This is a typical 37-year-old male who had back pain for nearly 5 years. So it has taken 5 years to develop this X-ray changes. Okay. Now, how do you differentiate this from an aging problem? If you see here, this is an age-related, that's called spondylophyte. It's slightly angled, where opposed to syndesmophyte, it is joining from one vertebra to another vertebra. We call that as a bamboo spine typically. We don't want that. This is probably a disease which is at least 7 to 10-year-old disease. Okay, which probably is not adequately treated. Yeah. Now, so sections of the spine, you see, if treatment doesn't happen in adequate time interval, bone grows out from the both sides of the vertebra and joints, and typically the movement of the spine gets restricted. So it affects cervical spine of the neck, thoracic spine, or the mid back, and the lumbar spine, and also the sacroiliac joint. This is sacroiliac joint is your buttock bone, your hip bone, spine bone. So this joint is sacroiliac joint, where we just saw on the previous on this section, that is this section which we saw. Okay, so in picture what you're seeing is this joint. Yeah, so connecting your hip joint to the buttock joint, this is the sacrum joint, this is the ilium bone. Okay. Now, what we don't want, my friends, is patients developing hip disease. See, this patient has developed erosion in the cup, hip cup, that is the hip bone. This is the leg bone or the femur head, which is the ball and socket, like that. It rotates like the ball and socket. Okay. So you're seeing that there's a hole there, that's erosion. That's necklace like osteoproliferation. It is written like a necklace. And osteophytes at the femoral head, you see all these edges are ragged, and you see that those are all pieces of bone. So if ankylosing spondylitis is not treated adequately, in about 10 years time they develop this, and once it develops we can't stop this, and they end up having hip replacement at the age of 35 to 40 years, which is terrible in my opinion, because every 10 15 years or 20 years joints needs to be replaced. So please come to rheumatologist early so this is prevented, because there are treatments now. If you start early, these changes can be prevented early, and exercises can be started early so that these changes. So this is a complication. Hip arthritis and ankylosing spondylitis. We don't want patients to develop this. Okay. Now, what is the use of MRI? So this patient, you see a normal, almost you can classify as a normal sacroiliac joint, or grade 2, you can say on one side. You ask an X-ray, this is what it shows. You ask an MRI, you see bone is swollen there. That's a typical MRI of the same joint, that is the pelvis joint. Because this is a sacroiliac joint, which I just showed, which is the sacrum of the buttock bone. This is the ilium bone on the right and the left. You see here, all these whitish areas are bone swelling in the bone because of this disease. The immune cells in the blood attacking that and swelling, causing buttock pain. That is where the buttock pain comes. That is where the hip pain comes. That is where the stiffness comes. Okay. In the same MRI, in a stir sequence, you see that it's all on this joint swollen or whitish color. Okay, we call that as bone edema, or periarticular bone edema, subchondral periarticular bone edema. That's what we call. And we also see the edges of the spine or entheses. What I showed on the X-ray, that is shiny corners or Romanov's lesions. So these, you see the whitish thing there. We see on the MRI, see the whitish thing there, whitish thing there. This is the one which produces the bone and connects this bone to this bone and causes enthesitis or bamboo spine. We don't want this again. So this is what we see in MRI. and this is profound. You see quite a bit. This patient must be in terrible pain because of severe bone swelling here, and also the back of the spine is also get affected, called facet joint, so causing severe pain and swelling. Yeah. So which all other complications might happen? Eye inflammation, I told you about uveitis. If untreated, ankylosing spondylitis can affect the lung, called fibrosis of the lung, deep breathing difficulty. And if associated with inflammatory bowel disease, it can cause colitis, where severe diarrhea, abdominal pain, not feeling hungry, weight loss, and diarrheal episodes in the night, mucus-like material coming out through the anus, through the feces. In severe cases, fever and all that. And some patients have difficulty to control urine. Okay. And some patients have heart rhythm disturbances, and also inflammation in certain parts of the heart. Psoriasis, I told you, in about 25 to 30% of patients have skin, flaky, inflamed skin, including nails and skin. And you have ankle problems where reflexes or ankle movements can be affected. And finally, because of inflammation, bone thickness gets reduced and osteoporosis, and you find young men with this disease having fractures, especially spine fractures, early in life because of bone weakness or bone brittleness, called osteoporosis. So the aim of a rheumatologist is to reduce your pain, to make sure you regain your physical function, and delay the structural or damage. I showed you the hip damage or the spine damage on the x-rays, which should not happen. Okay. So your options for treatment are mainly tablets or physiotherapy. And physiotherapy, surgical, we delay till the end. Our aim is to delay surgery. However, if the hip joints is completely fused or knee joint is completely damaged, then you need to have hip or knee replacement surgery. So there are experts, your rheumatologist will know, who deal with these things with minimal complications, not an issue at all. Okay. So if you look at the treatment options, the main thing which gives you a wow relief is what patients traditionally called as painkillers. These are non-steroidal anti-inflammatory drugs, NSAIDs. They are not steroids. They reduce pain and stiffness in virtually in about 80 to 90% of patients, and within an hour, and they improve quality of life. Some patients are addicted to it and they're not able to stop it. That's when we know the disease is quite high. And it can upset, especially if patients has inflammatory bowel disease, it can upset diarrhea, it can cause gastroenteritis, it can cause high BP or taken over a long time, or it can cause heart problems and so on and so forth because of fluid retention. But if handled by a rheumatologist, he or she will know how to monitor this and how best to reduce the dependence on it. There are also other safer pain relievers like paracetamol, which you can take, like Dolo, Calpol, Crocin, or even Ultracet, combination of tramadol and paracetamol. Steroids don't have major relief in this disease and opposed to rheumatoid. That's the major difference. If you give steroids, it will hardly work for 1 or 2 days or maximum 1 or 2 weeks. That includes intramuscular injection or even tablets. So tablets rarely given. Steroid drops are given for eye disease, and even tablets are given for eye disease in acute fashion. And sometimes if the knee is inflamed, knee injections can be given, or the hip is inflamed, sides of the hip, sometimes we do hip injection. Or in sometimes pregnant women, especially where we can't use tablets, sacroiliac joint can be injected through ultrasound guidance, so through expert radiologist under the supervision of a rheumatologist. Okay. Typically, what we use first line is conventional synthetic DMARDs or disease modifying anti-rheumatic therapy. Generally, it doesn't work greatly for just back pain. For if it is feet pain, ankle pain, hip pain, knee pain, or shoulder pain, it works greatly. We use combination of either sulfasalazine, or methotrexate, or leflunomide, one of these three agents. The best out of this is sulfasalazine. If its back is affected, the chances of success of these tablets on their own is very less. So they might work 50 to 60% only. But it takes 3 months to work. Remember, my friends, these tablets take 3 months minimum to work, 90 to 100 days. They don't work in one day. So you need to be patient for this to work. The rheumatologist calls you 1 month later to monitor the effects of tablets for 1 month, increase the dose. 2 months later, again they'll call you. Then they'll by third month you will be on adequate dose. Then if you're still not maintaining well, then they will think of other agents such as biological medicines, which I'll come to it shortly. Painkillers, I always tell you, non-steroidal anti-inflammatory drugs are not just painkillers, my friends, in your case. They have disease modifying effect. So feel free to take painkillers such as Voveron, ibuprofen, or Itoshine, or indomethacin, which actually um helps these diseases. So most of these have a 24-hour or 12 effect. So what I would say is, frequently use it. Normally, I give first 10 days regularly, then I give alternate days, next 10 days, then I give once in 3 days, next 10 days. Sometimes, if the disease is very high, I give for a month. And I also give something for stomach acids, like pantoprazole or omeprazole or rabeprazole to prevent gastritis. Sulfasalazine, we start typically with 500 mg and gradually increase it to 1000 mg morning, 1000 mg night. Full dose is 1000 mg morning, 1000 mg night. And after you take 1000 mg morning, 1000 mg night for 2 to 3 months, then only at post 50 to 60% of disease comes under control. We know that sulfasalazine or methotrexate or leflunomide is working when your dependence on painkiller comes down. If you're requiring painkillers, that is non-steroidal anti-inflammatory drugs such as Itoshine or Neucosia or Voveron or Indocap or Donica or any of these, then that if you're requiring on a daily basis or you're requiring on an alternate day basis, or if you're requiring 2 to 3 days in a week, then that shows that your tablets such as SAS or Sazo or Salazar or Rumalef or Lefno or Mexate or Folitrax or Oncotrex are not working. That's when we need to talk about biological agents. So biological agents are mainly in the form of injections. I'll come to it in a short while. So they are both the ones which are given self-administered by yourself on the thigh or abdomen, or given by a nurse in the daycare unit as we give in our clinic. And they're effective both in early and advanced stages. They reduce your symptoms, they reduce inflammation, they reduce pain. But while you're taking it, you will be remarkably better. But when you stop it, you may have symptoms back. So in developed countries where I train, in UK or in the US, once a diagnosis of ankylosing spondylitis is made, patients take this symptoms treatment, that is biological agents, without sulfasalazine or full of methotrexate or leflunomide or painkillers. They directly go on these agents because it will be government funded or insurance funded. In our country, the sad state of affairs is insurance doesn't cover this because there is an exclusion of autoimmune disease under our Insurance Act, which we rheumatologists are still fighting out and submitted memorandum to Union Health Ministry. We Karnataka rheumatologists have done that. We are still yet to receive any further progress. So that's where patients like you should raise awareness and form a group and inform the policymakers to amend insurance so that these biological agents, they are remarkable. They change your life. Some of you might be taking that, and they start working within 15 to 20 days, and your dependence on painkiller vanishes. And in India, at least I recommend 6 months to 1 year course, at least 6 months in most of my patients. After that, I stop and see if they are fine. Sulfasalazine or SAS continues. Sometimes I add Folitrax or Lefno, and I tell them, if you, after stopping biologic, if you get pain, then take painkillers. Stopping biologic is mainly for the cost concerns, nothing else. If cost is okay, you can continue them, and the rheumatologist might slowly increase the interval or reduce the frequency of taking. That is, if you're on a weekly injection, after 6 months, they might make it 2 weekly. If you're on a 2 weekly injection, they'll make it 3 weekly or monthly. And if you're on a 2 monthly injection, that is Infimab or Infliximab, Remicade, they might increase to 3 monthly or 4 monthly, because they stop the disease from getting worse. So they arrest the disease, the erosions or the bamboo spine and all those things might not happen. That power the SAS tablet doesn't have. And your dependence on painkiller comes down, thereby your side effects comes down with any of the medications. The only other concern about biological agents is this has to be thoroughly screened and prescribed only by a rheumatologist, because if there's any risk of TB, a rheumatologist can elicit in the history, that past history of TB, family history of TB, or we do MAD2 test, TB gold test, or sometimes chest X-ray. And if one of these are normal, then you don't need additional treatment. If not, we give 3 months of protective TB treatment. There are occasions where sometimes, even after the TB test is normal, yeah, even after taking protective TB treatment, very rarely, one in 500 patients might still develop TB while they're on this, and we stop the biological treatment, we give TB treatment, and they become better. Safety is excellent for these injections. It is life changing. It prevents further damage. Only thing, the cost is a problem. These days the monthly cost, whatever you take, depending on varies from somewhere between 24,000 to 30,000, depends on that. Some of the state government insurance schemes provide that. Okay, so they're called TNF alpha inhibitors. Rarely, a new agent called IL-17 blockers called secukinumab has come to them. Newly has come to the market in the last 2 to 3 years. So, especially works for psoriasis. It's called Scafo. Okay, some of you might be taking that. So, if you look at what are the agents we have, back in 2003 itself, both the American and European FDA is American, EMA is European, approved Enbrel or etanercept and their biosimilars, for ankylosing spondylitis, and infliximab, Remicade or Infimab in India, approved in 2004. Infimab has been there for last 5 years or so. Adalimumab, Humira is not there in India. We have biosimilars, that is Exemptia, Zydus Exemptia, or Adalimumab, from RPG. So they have these are the other ones. Adalimumab works very well. Etanercept works very well. Infliximab works very well. They all work the same. Sometimes patients, after taking this for some time, they develop immunogenicity. That is, the body themselves develop antibodies or drug resistance. Then we change the agent. So those who are using adalimumab, we give etanercept. Those who are giving etanercept, we give infliximab. The highest immunogenicity, that is loss of effect after a few years or few months of dosages, with infliximab or Remicade or Infimab, then followed by adalimumab, that is Exemptia or adalimumab or Adalipca, depending on what company you're using, and then followed by etanercept. So Enbrel has the least in terms of side effects, and also in terms of loss of efficacy. Patients can continue it without losing its effects for years together. Actually, it is a receptor blocker. Okay, it is given as a weekly injection. Enbrel. This is given as intravenous injection. We give loading dose of 0, 15, and 45 days, and 2 monthly after that. So normally I give 4 doses. After that, if patients require it, I give. Otherwise, I don't give in infliximab or infimab. It works quicker than Enbrel and Exemptia or Adalimumab. And adalimumab is once in 15 days, so monthly 2 shots. And golimumab is Symphony, which is from Johnson and Johnson. They gives a monthly shot, given monthly actually on your skin, so self-administered. Certolizumab was there in UK where I trained. It wasn't there in India. This is the only one which can be safely given throughout pregnancy. Now, in pregnancy, I'll come to it short while. SAS is safe in pregnancy, can be taken. Painkillers we don't give, we only give Dolo. And this biological agent, now the latest British Society of Rheumatology guidelines has been revised a few years ago. Then we give up until 6 months of pregnancy if need be. After that, we don't give. Okay, we can give again in breastfeeding as well. Secukinumab was Scafo. It blocks IL-17 receptor. So basically, it blocks IL-17 effects. It's there in India since 2016, and we typically work very well for psoriasis background. So again, the immunogenicity is not very well known with this. Probably it works. So it's a monthly injection after loading dose of weekly doses. So there are quite a few agents now compared to so this is as of February last year. Not much has changed after that. So if you look at adalimumab, it is given for rheumatoid, psoriatic, ankylosing spondylitis, GAA. Etanercept again for rheumatoid, psoriatic arthritis, ankylosing spondylitis, and kids having ankylosing spondylitis. And infimab, infliximab, it's not given for juvenile arthritis. Same thing with golimumab and certolizumab. Okay. Um, so let's see the effect of this TNF blockers. So this A is the MRI before the TNF injection. You see the typical sacral leg joint on the right, they're swollen there, and B you see with just which 48 weeks of therapy they say, that is about more than 6 months of therapy, it's fully cleared. And patients often ask, how do we know it's fully cleared? You do an MRI, it's fully cleared. You see, same thing here. You see the white arrows or shiny corners, all these edema. This is all cleared with this. And this is the knee joint or condyle inflammation is there along with enthesitis here at the muscle groups. So it's fully cleared. You see, it's all cleared there. Okay, so coming to the physiotherapy, this is very very important. Not just your biological agents or painkillers or SAS or Folitrax or Lefno. So you need pain management by physiotherapy team, regular exercises, massages by experts, and patient education is what non-drug treatment guidelines say. So if you look at exercises, it's the most important thing along with medicines. This should be your daily routine, like taking bath or eating food or going to toilet. It should be like that. You don't miss exercise every day. And range of movements is maintained with this. You maintain good posture and you develop muscle strength and muscle tone. It improves your breathing capacity, especially if your ribs are affected. It improves your balance or gait, and it improves your cardiovascular fitness with this disease. So it increases your flexibility of your joints, such as shoulder or elbow or hands or hips, knee, or even back. It helps in benefits of stiffness and pain. Patients often say, "So once I do the stretches, I feel much better." That's why we say do it daily, and increases the range of movement, improves your sleep quality. So if you do 30 minutes of aerobic physical activity, it releases internal endorphins, which makes you feel good, which develops self confidence, which increases your sleep quality. It makes you feel overall better. But that endorphins washes away in the urine in 12 hours. So you need a daily dose of that. That's very, 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 very important. Okay. So engage in some form of physical activity every day. Perform physiotherapy or doctor recommended muscle strengthening and mobility exercises. Do deep breathing exercises, including thoracic breathing, back, leg, shoulder stretching extension exercises, as long as they do not strain your neck. And range of motion exercises can help to reduce pain and stiffness. Patients often say this, "Sir, I have pain. What is it, sir? You're telling do exercise, do exercise." So I tell them, take NSAIDs or anti-inflammatory, then do it. It is recommended. Do painkillers and do exercises. That's when your improvement will be there. So please listen to this. Your physio might do something called muscle stimulation by using this transcutaneous electrical nerve stimulation. So small electronic pads might be attached like this, and pulses sends pulses to nerve endings. Painful areas might get relief by giving some tingling sensation, and it alters the pain messages sent to your brain. So that's how it is. So you contact your physio, your doctor center. They might be able to provide. Physios offer a great deal of support to these patients. You must contact a physiotherapy with ankylosing spondylitis or back pain. Please remember this. Only tablets does not give you relief. You must have a physio at least 5 to 7 days of session. You might spend time with them, record the sessions with them, keep doing exercises. And normally when the patient is in very severe state, 1 month I don't give exercises. I just tell them to walk initially and do some basic stretches. A month later is when the pain level comes down. I let my physios to take over and do the relevant stretches. We also have therapeutic yoga. We have a dedicated PhD therapeutic yoga teacher who comes once a week within our center. So you can find one near your house also, who does yoga. General yoga might harm you, might damage your enthesis or spine. So if your yoga teacher knows what therapeutic yoga is, they would have studied musculoskeletal anatomy. Some of the physios do therapeutic yoga. So specified asanas for this are quite important when it comes to ankylosing spondylitis. General yoga doing with general public might be bad. Your pain level might increase. Massage. Often patients ask this, so never take hard Kerala massage, which they do with elbow. You will be totally gone. So all your inflammation will be. Only thing you have to tell them, use your palm of the hand and do soft massage, please. Soft massage is just wrist is firm massage, elbow is hard massage. So palm only, no hard pressing like that. Tell your massage therapist. It improves, morning stiffness and joint mobility, improves quality of sleep. But massage might trigger when you have flare-ups. This is not main therapy. This is all add-on supportive treatments. You need either tablets or these injections. Along with that, you need exercises, and massage and all are symptomatic therapy. They're not the main therapy, please. Physiotherapy is not the main therapy. You need tablets along with physio. Like, so it's all combination treatment, combination. Everything should come in. You are at the center, rheumatologist, physiotherapist, they're all working with you, so that it's a teamwork. It's a teamwork. Very, very important. Surgeries at the end, like I said, completely damaged hip surgery, hip and knees. You need surgery to be done by an expert surgeon who does joint replacements. It aims at removing pain and improving mobility. If your mobility is very bad and your X-ray is showing severe disease, get surgery done. It will greatly improve your mobility. And it has to be done. So spine surgeries I rarely refer. If somebody has fully bent neck and they are not able to see, then wedge osteotomy done to improve neck movement. But you might have other things like disc problems or nerve root compression or spinal canal stenosis. That I think the surgeons have strict criteria for operations. You might ask your rheumatologist when to see them. They will tell you. Okay. So behavioral lifestyle recommendations are very important. Maintain proper posture at work, at leisure, and while sleeping. Avoid overtiring. Don't do all work in one time. Divide it into, instead of 4 hours of continuous work, divide it into 1 hour short work and with small breaks. Avoid becoming overweight. Overweight increases inflammation. Overweight increases load on the muscle groups. Overweight increases your pressure on the joints. So weight reduction itself, some of my patients have gone through bariatric surgeries, inflammation has vanished. Okay, so it's well known fact that adipose tissue increases CSR on inflammation. Smoking, my friends, 50% of disease is gone if you stop smoking. So never ever go back to smoking, because it alters your HLA-B27 gene. It makes it more villainous. Your HLA-B27 gene is the one which keeps sending signals to the immune system to say attack this person, attack this person, attack this person. And smoking always gives charge. It's like the toy which you charge and leave and it clamps. So the smoking always charges the HLA-B27 gene. On one hand, the exercises, tablets, and biologic therapy, if it reduces the HLA-B27 curve, if you smoke even one puff a day or a week or ever in your life, you've had it. Do not go to smoking, please. I request you, please stop smoking. Very, very important for ankylosing spondylitis, my friends. Not even passive smoking is allowed. Please, if you are in the habit of smoking, your tablets don't work. Biologics works only 50% even after you spend so much of money. So never ever do that. Okay. I always tell my patients, do not smoke, do not smoke, do not smoke. Maintain a good attitude. Don't be negative. I read Google. Google says your life is finished. My neighbor said you're doomed. You're taking this tablet. You're on. No. Whatever it is, I will achieve. I will have my goal. I will become successful. I will not be happy. I will come out of this. I have my doctor. I have my physiotherapist. I will aim everything I can do. Very, very important, my friends. Very, very important. Disease is not first. You are first. If you come first, disease comes second. If you are weak, disease plays on your mind. If you are strong, disease comes under control. So make yourself very strong. Practice meditation or spiritual, whatever suits you. Positive mental attitude, my friend. Please, positive mental attitude. However, this is your severe. Never lose hope. Never lose hope. We are here to help you out. We are here to help you out. Never lose hope. Even if you're having bad days, seek help, never give up. Okay, that is something very, very important, my friends. So these days, work from home, very important that don't sit for a long time. Every 20 minutes, take break, take a few minutes of walk, and then come and sit back. Maintain good posture. Prolonged stooping, bending not advisable. Make sure your work environment is, cozy, very cold, AC and all. Not advisable. AC is not a decor. Wear uppers. I always tell socks, food and all. And say, alternate between sitting, standing, walking. Keep changing your posture, my friends. Keep changing your posture every 20 minutes, my friends. Every 20 minutes, keep changing your posture. That helps you a lot. And sleep. I'll come back how to sleep. So avoid occupations that involve strong bending, twisting, stretching, body vibrations, and all that. See if you can relocate yourself if you're in one of those work professions. Okay. Then sleeping. A firm or orthopedic mattress or flat mattress is best. Not too soft, not too hard. Always sleep on your back, not like this. Sleep on your back to prevent bending of the back and hip joints. But sleep like this when you're about to fall asleep. Lie on your front before falling asleep and before rising up in the morning. Before rising up in the morning and before falling asleep, fall on your or sleep on your front. That reduces your pain and stiffness when you get up. But other times sleep on your back. Avoid large pillows that lift your shoulders and bend your spine. Don't keep too many pillows. Okay. Walking. Take large steps and to prevent hip joint limitation of hip joint. Don't walk small steps. Wear shoes with shock absorbing heels. Complete flat foot with no heels. Bad shoes for these patients. Okay. Then sports recreation. Choose sports based on your state of disease and no limitations. Activities that promote good posture, extending rotation of trunk, like swimming, is very important. Now these days, COVID situation, don't even venture there. It's closed anyway. Sports requiring extended periods of spinal flexion, like as golf, bowling, long distance cycling, may not be advisable. Okay, avoid sports with high risk of injury. Football, boxing, skiing, you may not be able to sustain that. Singing or playing musical instrument can improve breathing or lung capacity. Think about it. Okay. Then driving. Wide view mirrors can increase visibility for patients with limited neck mobility. Always use seat belts and head restraints. A back cushion might be helpful. Don't do prolonged driving. Take break after every 1 hour. Stretch around and walk if you can. And carry emergency information about disease and treatment and special needs. Yeah. Wear anti-skid shoes, fall prevention. Use railings when you are going on stairs. Consider using shower stall instead of a bathtub, like walk-in shower. Use a bathtub or grab bars to avoid slipping after you come out of bathroom. Avoid slippery surfaces and loose carpet, and use floor lighting at night. Okay, these are recommended behavior and lifestyle changes. Sex. Most patients have trouble talking to doctors. They are all young patients, 15 to 35 years, 45 years, both men and women, men especially. Talk to your doctor about it. Don't hesitate. Say that, sir, I have problem having sex because of pain. So adjust your position as to reduce pressure on hips. Take a painkiller before having sex. Not a problem with that. Before you have intercourse with your partner. And it should not restrict love making or sexual activity in most cases. If you're having trouble, male or female, talk to your spouses or your partners that this is the problem. Don't keep mum, because that will affect your interpersonal relationships. Very important. Okay. And talk to your doctor, please. Yeah. So, behavioral and lifestyle recommendations in fertility and pregnancy. Ankylosing spondylitis does not have problem with conception. Doctor, I'm not getting pregnant. Female patients telling, or male patient telling, my wife is not getting pregnant. Does this disease affect? No, it does not affect you to conceive. However, pre-pregnancy planning, either men or women, talk to your doctor. And women, if with this disease, with severe hip joint disease, even may not have full problem, but with very high active disease, talk to your doctor whether you can use a biological agent to reduce your disease and then get conceived. Okay. To avoid complications, tablets as far as possible should be avoided in pregnancy. But if you're on SAS, it's safe to continue along with folic acid medicine we give with SAS. And if you're taking methotrexate 3 months before pregnancy, it should be stopped. Leflunomide typically should be stopped 2 years before planning pregnancy, or if sudden pregnancy happens, then you might have to use washout regime, cholestyramine washout. Talk to your doctor about it. For TNF blocking agents, that is biological agents, so we generally say at pregnancy test positive we stop. However, if disease is severe, we continue until 6 months of pregnancy, and even breastfeeding is allowed. SAS is safe in breastfeeding. So, to compensate in pregnancy, for the tablets, you're not able to take painkillers, is strictly not allowed except paracetamol. You have to, devise an exercise program, speak to your physio about it. Diet. So what do I eat, doctor? So avoid taking excessive starch. Take a low starch diet, that has excessive rice, excessive potato, excessive sugar, sweets, excessive butter, cheese, paneer, dalda, fried items, excessive red meat. Don't take all of these. What I used excessive, don't take. Don't take. That is at the top of this pyramid. Okay, all of this. What you must eat is more of green leafy vegetables, other vegetables other than potato, flax seeds, walnuts, olive oil for cooking, and chicken, fish, egg is okay. Increase omega-3 fatty acids in your diet. Increase consumption of vegetarian meals, and sufficient vitamin D and calcium. That is, dairy is fine. Low-fat dairy is absolutely okay, not an issue at all. Processed food, strict no. Anything packeted, don't take. Eating externally outside Swiggy, Zomato, please. No. Lot of fried food, processed food, baking soda and all they add. Once in a while, once a month, okay, not regularly. And alcohol, generally excessive alcohol increases, especially psoriasis, increases inflammation, might interfere with tablet. So reduce your consumption of alcohol. If possible, do it once weekly only, and do not cross more than 3 units of alcohol in a night, whatever you're taking, either wine or whiskey or beer or whatever. If possible, quit it. If not, you're not able to enjoy, do it once a week only. Don't do more than that. If possible, even if you reduce that, better. Smoking, strictly no smoking, please. Okay. So this is about the diet part. So important things, see doctor often. Why doctor keeps calling again and again, sir? Same test again and again. That is to monitor monitor your tablets, monitor your side effects. It's causing anything, we don't have fun in seeing you. It is because of your own safety, please understand. And follow treatment plan that your doctor gives you. Stay active with regular exercise. I do whenever I like, sir, exercise. Don't say be active, don't be a lazy bum. Okay. Maintain healthy diet, good posture, don't smoke. So these are the important things. Okay. So good news is, even if you're diagnosed, you are much better off. If your diagnosis was 20 years ago, they have much better quality of life now with ankylosing spondylitis. And you know with Stand for AS is a brilliant initiative which Dr. Shashank Ankerkar and his team from Mumbai, is a Mumbai rheumatologist. Some of you might be knowing him, or some of you might be members of Stand for AS. It's a brilliant organization. Who are not members, please do member. There's a Facebook page for that, and regular updates are given. Regular videos by Shashank and team has been done. So it's a great to discuss and allay your anxiety. However, I've seen some of the Facebook pages there. Beware of some of the things which says that this treatment cures that, this treatment this. Okay, so beware of false messages, even the groups also. So stick to your rheumatologist advice and consider joining this. Dr. Shashank Akir from Mumbai has developed this, and it's quite important you, because these are groups are important to influence policy makers, decision makers, to change like insurance laws and other things. Okay. And whenever rheumatologists call you for some of the things for patient awareness programs, please do attend, because that is where we'll be calling all the policymakers, secretariats, and politicians, so that we give them memoranda to approve your biological agents for insurance, private insurance, and other things. Okay, that's my sincere request, my friends. And even Indian Rheumatology Association (IRA), both at the Karnataka level and the national level, has patient groups. So make sure you participate in that. So these are my YouTube videos of various diseases in rheumatology. I have a separate one on ankylosing spondylitis, the one here. You might take a photo of this and visit this. And I have separate things on what is arthritis, long-term effects of rheumatoid, diagnosis of rheumatoid, arthritis and age. For this topic, ankylosing spondylitis, this one. Okay. So this is my last slide. I thank you all for patient hearing. I started about 10 minutes late. That's why I ended late. And very, very grateful for you to attend this. And trust Divisha for all your care. I thank my staff for looking after our patients very well. And may God bless all of you. Uh, and let all of my patients be happy and be confident. Thank you very much. Now I'll address questions. So, Bimla Goyal, 2 days ago, I have severe pain in right heel. My physician said it's a spur and knee pain since 5 years. Bimla, you must meet a rheumatologist wherever you are. This looks like ankylosing spondylitis with peripheral joints causing plantar fasciitis and and inflammatory arthritis in the ribs. Okay. Ranjita Vinay. Sir, is physical deformity common in spondyloarthropathy? Can it be reversed? Physical deformity, Ranjita, is in two forms. In the early stages, inflammatory stage, it can be reversed with your treatment, either tablets or biologicals and physiotherapy. If it's bone damage, like I say, if the hip joint is eroded or your knee joint is eroded, then you need knee replacement surgery where it will be reversed. Santosh would like to know more about the AS. Sure, Santosh, you can visit my YouTube page. You can visit for ankylosing spondylitis. This one, I'll have more detailed information on that. Okay. Uh, then, right. 1 minute. Let me just get this in proper alignment. Yeah. Okay. Then Shivkumar, by taking proper medication, is possible to completely cure. Sir, complete control is possible, Shivkumar sir, but cure means removing treatment. That will take some time. Your rheumatologist will be able to handle that, but you will be able to lead a pain-free life without pain with treatment, sir. And we aim to reduce your deformity, disability as much as possible. Premanand, doctor, can this lead to heavy chest pain leading to breathing difficulties, gastric pain, and food ulcers in food pipe? Yeah, it can affect Premanand. It can affect chest and rib bones. Chest and rib bones it can affect, and that can cause breathing difficulty. But with painkiller tablets, you might have gastric ulcers, or so that you'll have to discuss with your doctor using protective medicines to reduce gastric problems. Avoid tea, coffee, excessive chili, and those lifestyle changes. Uh, Doctor, can it lead to lichen nitidus on the arms and skin? No, I wouldn't think so, sir. You need to discuss with the dermatologist regarding this. Godwin, sir, thanks for letting me know you're here by putting an XX. Thank you for joining. Miss Sangeeta, how can we relieve from pain? Will what will be the daily routine? So, stretches daily, painkillers if you require, regular SAS medicines, and if disease is very severe, biological treatment. Or if you relieve, talk to your doctor. Um, is what you need to do. Daily routine, your exercises should be your daily routine. That's what is the main thing. Varun says I have C6, C7 disc problem. Varun, that's a totally different disease you're talking about. Visit your rheumatologist or visit us. We talk to in detail. We have an online consultation also. Sandhya, madam. Okay, thank you very much. Hello, doctor. Good to know that you're conducting this webinar. Nagging pain during action at shoulder joint, arm sleeve, folding elbow also. I feel better during arm stretching exercises. I've been experiencing this more than 2 months. I have severe cervical lumbar spondylosis. Looking for solution, waiting to hear you in the webinar. Thank you very much, Madam Sandhya. I hope this was beneficial to you. And feel free to contact us if there's any other question on this. How do you manage biological while traveling? Shubhanai Gupta, basically you need to carry a ice. Most of the companies give that now, most of the clinics, where there'll be gel ice which stays in that ice pack for without fridge for nearly 4 days. I'm told if it's in a thermocouple ice box, well packed, it stays for 4 days, or at least it'll stay for 8 hours at least. So you can take it in nearest fridge when you get. You can keep biologic there. Okay. Does biologic need to continue long? Depends. I don't continue beyond 6 months, and I stop and see if it relapses and to an extent where it was worse than before or same as before. Then I do start it at a staggered interval, but minimum of 6 to 1 year is what would be beneficial. Sham Kumar, thanks for attending. Sridhara, spondylitis related to sometimes left shoulder, back, and heel numbness. Please visit a rheumatologist or visit us for further history and examination, Sridhara, and test whatever you have. We'll go through that in detail. Timmappa, I'm back pain and knee pain as well as AS. I was followed your prescription. It's a part of your disease, sir. It takes some time. Another 2 months you'll get there. So you've been started on treatment. It gradually will resolve. We can take your painkiller tablet, Ultraset whenever required. Okay. Um, Food restrictions, Bharati. Avoid red meat consumption. Avoid butter, ghee, paneer, cheese, dalda, fried items. Avoid sugar, excessive sweets. Avoid potato. Take rice in less quantities. And don't take excess quantities of food. Small portions, frequent intervals is fine. No, spondylitis and RA are both different diseases, Bharati. Both are not same. Even after taking Adfra 12 injections, food problem has not been fixed. So it depends on which part of the foot. Is it actually inflammation or it's a mechanical problem? So you need to visit us back or visit a rheumatologist nearby. If you're our patient, visit us back either on video consultation or here. You need to examine and go through in detail whether that part is reversible. Okay. Um, Satish, can we get the presentation? Sure, sir. I'll ask the company to provide it. Sangeeta, what will be the best solution for pain? Hip joint, SAS not working properly. So, Sangeeta, painkiller is you can take it on an alternate day basis or once in 3 days. It reduces inflammation if your SAS is working. But even if your painkiller is not working, then if you are our patient, consult us, or if, other rheumatology patient, consult other rheumatologists for biological treatment discussion. Sheila Jalihal, bones getting brittle, prone to fracture, that is osteoporosis, madam. For that, you need DEXA scan to see your T scores, and you need calcium and bone protecting agents. Please see us or other rheumatologists nearby to discuss options for osteoporosis. Um, Sunita, madam, I missed the beginning. Sure, madam, I'll try and get a copy and send it out to all my patients. Sudipto Chatterjee, details of physiotherapist in Kolkata, as the patient is in Kolkata. I can't go to Divisha. Sure, sir, you contact our appointment number. We can provide you a local physiotherapy there. That is 9916777044 is our appointment number. You contact us there. Any patient you want any information regarding video consultation, or physiotherapy or other doctor consultation, or nearest rheumatologist nearby, please contact that number. We'll be able to help you out. Shalini, madam, my MRI is normal, RA factor is negative, HLA between negative. After all this and negative, do I still have ankylosing spondylitis? Shalini, if MRI is normal, I don't know what normal means. I need to see the MRI. Sometimes the report is normal, but a rheumatologist needs to see the MRI. So if you are in Bangalore, visit us. If you're not, we take a video consultation. Through video, I'll go through your MRI images. If you have typical inflammatory back symptoms, early morning stiffness, pain in the lower back, first thing in the morning very stiff, later half of the night very stiff, better with painkillers, better with movement, then most likely you're developing an ankylosing spondylitis. So I would like HLA-B27 negative is good, reassuring. But MRI, I need to see that. If you're not having any of the symptoms I told, maybe you're not having ankylosing spondylitis, you're having muscular back pains. For that, also see us. Arunachalam, thank you very much for attending. What happens if I miss a dose of biological therapy? Generally, your disease might flare up, and you'll probably also develop something called as anti-drug antibodies. So consult your rheumatologist. Do not miss any prescribed doses. So that will lead to potential problems of losing its effect. Okay. Ramakrishna, thank you for the webinar. Condition was very well addressed. You know well about it. Thank you very much, sir. The idea is to benefit all patients. Anil Kumar, thank you very much for ankylosing spondylitis. Thank you. Varun, thank you. Thank you for attending. Balance, Madam Sangeeta, you need to visit a physiotherapy for balance training. So they will do gait assessment and gait training. That will be very important. Okay. And acupuncture recommended treatment for RA, not the main treatment, madam. It might help you for pain relief, but it won't last for long. So you need effective anti-inflammatory therapies. Thank you, Sunita, madam, for attending. Acupuncture might give you symptomatic relief, but not in a very extensive disease like yours. Maheshwari, ಮೇಡಮ್ ಐ ಆಮ್ ವೆರಿ ಸಾರಿ ಮಹೇಶ್ವರಿ ಮೇಡಮ್ ಅವರೇ. ಲಾಸ್ಟ್ ಟೈಮ್ ನಾನು ಕನ್ನಡದಲ್ಲೂ ಮಾತಾಡಿದೆ. ಐ ಸ್ಪೋಕ್ ಇನ್ ಕನ್ನಡ, ಬಟ್ ಐ ಕುಡ್ ನಾಟ್ ಬಿಕಾಸ್ ದಿಸ್ ಇಸ್ ಅ ಲೆಂತಿ ಸೆಷನ್. ಸ್ಪೀಕಿಂಗ್ ಇನ್ ಟೂ ಲ್ಯಾಂಗ್ವೇಜಸ್ ವಿಲ್ ಬಿ ವೆರಿ ಡಿಫಿಕಲ್ಟ್. ಐ ಅಪಾಲಜೈಸ್ ಫಾರ್ ಆಲ್ ಮೈ ಕನ್ನಡ ಪೇಷಂಟ್ಸ್. ನನ್ನನ್ನು ಕ್ಷಮಿಸ್ಬಿಡಿ. ಬಟ್ ಇನ್ಫಾರ್ಮೇಶನ್ ಬೇಕಿದ್ರೆ ನನ್ನನ್ನು ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿ, ನಾನು ಕನ್ನಡದಲ್ಲಿ ಅದನ್ನು ಅನುವಾದಿಸುತ್ತೇನೆ. I thank you and apologize all the non इंग्लिश स्पीकिंग वर्नाक्युलर इवन हिंदी पेशेंट्स. मुझे क्षमा कर दीजिए, डिटेल में मैं हिंदी में बात नहीं कर सका. एक लैंग्वेज में ही 1 घंटा लग गया बात करने के लिए. आप सबको धन्यवाद. निम्ಗೆಲ್ಲರೂ ಧನ್ಯವಾದ. Thank you very much, and may you all live in happiness and peace. Thank you very much.